time for presentation and questions. Thanks everyone for being here. This is as you can probably tell, is a regular Zoom format. So if you do want to put yourself on camera at some point later to ask questions, that's totally fine. So today's talk is harnessing the power of spatial data science to help end the HIV epidemic in the United States. I'm Daniel Davidson, one of the program directors at CIRA, which is the Center for Interdisciplinary Research on AIDS at Yale University. We're part of the Yale School of Public Health, and we're funded by the National Institutes of Mental Health. We aim to provide a strong foundation of HIV-related resources, skills, services, training, and professional networking opportunities to HIV researchers and practitioners to enable them to contribute to advances in HIV prevention and treatment and health equity in general. So the sponsors of today's talk are CIRA's Dissemination and Implementation Science Methods Core, along with READY, which stands for the Rigorous, Rapid, and Relevant Evidence Adaptation and Implementation to End the HIV Epidemic Hub, which is also based here at Yale. All right, I will introduce our guests today. So Dr. Henry Luan is Assistant Professor in Spatial Epidemiology in the O'Donnell School of Public Health at UT Southwestern Medical Center. He applies and develops Bayesian spatiotemporal statistical models and advanced geographic information science, or GIS, approaches to investigate how health phenomena, with a recent focus on HIV and PrEP accessibility, vary over space, time, and race ethnicity, and how socioeconomic, demographic, physical, and built environmental factors contribute to these space-time and racial ethnic variations. His research program focuses on promoting the application of spatiotemporal analysis and GIS in public health, informing the development of geographically tailored evidence-based health interventions, and ultimately improving population health. And then after the talk, we will have time for questions, which will be led off by our discussant, Dr. Lorraine T. Dean, Associate Professor at the Johns Hopkins Bloomberg School of Public Health. Dr. Dean is a social epidemiologist who examines how privilege and disadvantage influence chronic disease and teaches an award-winning course on the topic. I'm going to close my slides and hand it over to Dr. Luan.
Thank you so much for a very nice introduction, Daniel. So hi, everyone. Thank you so much for attending this talk. So my talk today is harnessing the power of spatial data science to help end the HIV epidemic in the US. So here, spatial data science, like in short, it is a subset of data science and intersects with traditional geographic information science. And for information, spatial data science, in spatial data science, the location, distance, and spatial interaction are considered as core aspects in the analysis rather than additional attributes. And this is also key to analyze health HIV data sets, so which we will see in the following slide. So my talk today is a mix of my previous work and some of my ongoing work in HIV and PrEP. So in this talk, I will first briefly introduce the spatial nature of the HIV epidemic in the United States. In other words, why spatial matters. After that, I will discuss three essential tasks in ending the HIV epidemic initiative. First, statistical modeling of HIV data sets. This is essential for HIV surveillance because we need to detect the existing clusters and emerging hotspots. And those spatially explicit methods are needed. And we need to address challenges such as spatial autocorrelation, data sensory, if we are using the open HIV data sets, especially moving from the large area level analysis, such as states, to smaller area level analysis, such as counties, zip codes, census tracts, and so on. Second, measuring spatial accessibility of HIV-related resources. So this is the first step for identifying areas where resources are needed or demands are not met. So I will compare the simple and complex measures using PrEP accessibility as an example. And next, where should be intervened? Because after we identify areas in need of HIV resources, so this is the next question we need to investigate or examine. And this question can be informed by utilizing objective approach, the spatial optimization approach for resource allocation and allocation. However, these three methods, like including spatial statistical modeling, measuring spatial accessibility of HIV resources using GIS, especially advanced GIS methods, and spatial optimization, are challenging for most health researchers and practitioners. And to the best of my knowledge, no web tools with user interfaces have implemented these techniques. So that's the major motivation why we propose to develop a web tool to implement these techniques. And at the final section, I'm going to introduce a web tool that we propose to implement spatial data science techniques for HIV data analysis. Okay, so let's first have a look at the inherent spatial nature of HIV epidemic in the United States. So probably most of you know that as a major public health issue in the US, the HIV disproportionately impacts the South. So although the South states make up roughly 1/3 of the national population, they account for approximately 44% of all people living with HIV. And we can see, as we can see from the map on the left map, HIV prevalence is especially high in states including Mississippi, Alabama, Georgia, South Carolina, and Florida. And unfortunately, the uptake of pre-exposure prophylaxis, PrEP, biomedicine that has been proven to be effective in preventing HIV transmission, is low in these states in the South, as we can see on the right map. So from these two maps, we can also observe both the spatial clustering and the spatial heterogeneity of HIV and PrEP uses at the county level. And these spatial variations or spatial unevenness occur at finer spatial scales. So take Texas as an example. From the left map, we can see that the state as a whole has one of the highest new HIV diagnosis rates in the nation. But the rate varies across counties and across zip code tabulation areas, so which we can see in the middle and the right map. So from the map in the middle at the county level, so most counties, they have a zero rate between the 5-year period 2017 to 2021. And the counties with higher rates of new HIV diagnoses locate in the west, and some counties scattered within the state. And if we look at this phenomenon at a finer spatial scale, the zip code level, and for the DFW area, we can see that the central Fort Worth, Arlington, and central and South Dallas have the highest rate of new HIV diagnoses. So this uneven spatial distribution of HIV suggests that it probably is needed to dive into finer spatial scales to look at these phenomena in order to maximize the effectiveness of response or interventions to this public health challenge. So unsurprisingly, acknowledging the spatial distribution of HIV infections, in 2019, the Department of Health and Human Services launched the EHE initiative, aiming to reduce new HIV infections by 90% by 2030. Specifically, the initiative prioritized 57 jurisdictions in the nation, including 48 counties, DC, Puerto Rico, and 7 states. And unsurprisingly, most of them locate in the South. So for this initiative, there are 4 key strategies, including diagnosis, treatment, prevention, and response. And these key strategies also have an inherent spatial component, because to make the most impact from these strategies, we needed to know where are the areas that are in shortage of HIV diagnosis, treatment, and prevention services. Where are the HIV hotspots or emerging HIV outbreaks that we should prioritize for interventions and resource allocations? And what factors contribute to these hotspots or emerging outbreaks? and we can modify to reduce HIV transmission. So answers to these where questions rely on spatial data science techniques. And in the following slides, I'm going to illustrate how we can utilize these techniques to address specific challenges and how the solution will be implemented in the web tool we proposed. So first, statistical modeling of HIV data sets. Again, so this is essential for HIV surveillance and closely related to the response pillar of the initiative. However, there are challenges when we are modeling the spatial HIV data set, especially at small area levels. So the first one is spatial autocorrelation. So, and from previous literature, there are local clusters of HIV diagnosis, linkage to care, viral load suppression, and as we can see on these two maps. And these local clusters are usually detected by using spatial methods, such as the local variance I, Gary C, etc. And from the maps on the slide, the left map shows the clusters of linkage to healthcare, map A, and the clusters of viral suppression, map B. So the dark red areas are the hotspots of linkage to HIV care or viral suppression, and the dark blue areas are the cold spots of linkage to HIV care or viral suppression. And from the right map, we also see the clusters of HIV rates at the census tract level in Mississippi between 2008 and 2014. Again, the red are the hotspots and blue are cold spots. So it is not surprising to observe these clusters or hotspots or cold spots, because according to the first law of geography, everything is related to everything else, and near things are more related than distant things. So in HIV, these spatial clustering, as well as the spatial heterogeneity, are probably driven by the social determinants of health and other risk factors. But this leads to the issue that the observations are not independent from each other. In other words, we will need to explicitly address these like spatial correlation in the analysis. That's why we need to refer to the spatial statistical modeling approaches. And that's also why some spatial regression techniques, including spatial error and spatial lag models, are used to analyze spatial HIV data sets. So while these methods, including spatial error and spatial lag, are readily available in software such as GeoDA, they are limited in modeling discrete outcomes, such as the count of new HIV diagnoses, and they cannot adequately address the small number problem, especially at the small area levels, because HIV risk estimates could be unstable at the small area level. These challenges can be flexibly addressed with Bayesian spatial statistical modeling, which has two notable advantages. First is flexibility in addressing spatial correlation via, for example, the spatial random effects in the model. And the second is capacity in quantifying uncertainties in statistical inferences, because for all those unknown parameters, including the risk estimate parameters, we have the full posterior probabilities of these unknown parameters, so we can assess the uncertainties associated with the estimates. And while Bayesian spatial modeling has been applied in HIV research, but they are not as common. One potential barrier is that in most cases, the experience with programming and statistics is required, which is challenging to those non-statisticians and non-programmers, even though Bayesian spatial statistical modeling in the past decade has been made increasingly available and accessible via software and tools, including Winbugs, Arena, Limbo, and STEM. And this modeling is computationally demanding if they are implemented with the posterior sampling approach, in particular, Markov-Chain Monte Carlo MCMC, rather than posterior approximation approaches via INA. And to the best of our knowledge, no web tool has supported Bayesian spatial modeling via interactive user interfaces in online platforms, including AceView. So that's again, the motivation why we propose this web tool to implement these methods. And statistical modeling of spatial HIV data sets face additional challenges. beyond spatial autocorrelation if we were using the open data set. And of course, there are some advantages of using open data sets, including that we can usually they can be available at the nationwide. For example, like ACView provides HIV and related data sets at different spatial scales across time for the whole nation. And to use these nationwide data sets, we do not have to sign data use agreement with health departments at different levels. So that significantly shortens the time avoids or shortens the time of internal review. But analyzing these open HIV data sets face many challenges, and one of them is data censoring. Because we need to protect the confidentiality and personal privacy associated with the data set. And for example, in ACView, the count of new HIV diagnoses within the range 1 and 4 are suppressed from releasing to the public. And this map shows the new HIV diagnoses per 10K population in Mississippi at the county level between 2014 and 2018. And they show that a substantial number of counties' new HIV diagnosis rates are suppressed during this time period. And this issue prevents us from seeing the picture of this geographic phenomenon. And if this data suppression issue is not properly addressed, so it could lead to biased statistical inferences and bias in geographical pattern detection. And when intertwined with the spatial autocorrelation issue, the statistical modeling becomes more challenging. And in practice, different methods have been proposed to address this data suppression issue. And those conventional methods include data deletion issue, that we omit the suppressed values from the analysis. But this approach deletes a substantial amount of information if the suppression rate is high. So that has the potential to lead to biased estimates. Of course, we also have the data substitution approach, that we substitute the suppressed values at a small area level, such as counties, with the usually available values at a larger area level, so for example, state level. So, however, the findings could be biased if we use the data substitution approach, especially when the patterns at the small area level does not follow or align with the patterns at the larger area level. In addition, this data substitution approach introduces uncertainty into the analysis that cannot be accounted for in the final statistical inferences. And we also have the multiple imputation approach, that we impute the suppressed values multiple times, like 5, 10, 20, or 100, and then we perform statistical analysis for each of the complete imputed data sets and combine the results together. So that would be our final estimate. But this, it is challenging to use this multiple imputation approach by keeping the spatial structure in the data set and utilize the spatial autocorrelation feature for the imputation. And that's why we can refer to this Bayesian approach in dealing with suppressed values, which is another promising approach, but is underused in the literature, even though this approach has the advantage of treating the suppressed values as unknown parameters. So in this case, we can provide a full distribution for it, the posterior distribution, and we can also directly propagate the uncertainties into the final statistical inferences, which cannot be done in the previous conventional methods. Let alone that this Bayesian approach, as I mentioned in the previous slide, it is more flexible in fitting data sets with complex spatial and spatiotemporal structures. So in one of my recent publications, we used a hierarchical Bayesian spatiotemporal model to analyze the new HIV diagnosis in Mississippi at the county level between the time period 2014 to 2018. So I'm not going to introduce the models in detail on this slide, because this is not the focus of this talk. But I want to highlight several things in the model that we applied. First, as you can see in level 1 data model, so if the values are suppressed, so we are using a truncated Poisson distribution to model these values. So these truncated distribution restrict the sampling value to the range 1 and 4, which is indicated by the I function. So values will be sampled from these ranges only. So in this case, the full data sets will be used, or the full information will be used for statistical inferences, rather than being removed from the analysis. So second, in level 2 process model, we decompose the overall spatiotemporal variations in new HIV diagnosis into a combination of the main spatial pattern and temporal pattern and the local departures. We will see the results at the following slide. And finally, we use a Leroux prior to account for different levels of spatial correlation in the data set. So this Bayesian approach allows us to see a full picture of the phenomenon. So as you can see that we have an imputation for every or estimation for every county in Mississippi. So this map, the map on this slide shows the posterior mean of the estimations. But meanwhile, we can also quantify the uncertainties associated with these imputation results, because for each county, we have the full posterior probabilities of the estimation. So we can calculate, for example, the 95% credible interval, posterior standard deviation, and so on to quantify the uncertainties with our estimation. And this model also allows us to quantify first the main spatial patterns of new HIV diagnosis, which reveal the counties that constantly have higher rates of new HIV diagnosis regardless of time, which can be termed as a spatial hotspots, as shown in map A1. But meanwhile, we can also show the uncertainty of these spatial hotspots using exceedance probability, as shown in A2. So second, from this model, we can quantify the state-level trend of new HIV diagnosis in Mississippi during the 5-year time period. So you can see that there's no significant decreasing or increasing, which means there is a stable trend of new HIV diagnosis in Mississippi at the state level. And finally, we can quantify or show the local departures of new HIV diagnosis from the stable state level trend, because in practice, we wouldn't be expecting all counties in Mississippi to have the same trend. And specifically in Mississippi, the county Hinds and the county DeSoto, respectively, have a decreasing and increasing trend compared with the stable trend at the state level. For more information, if you are interested, you can refer to my article published in 2023. So even though our results from this study indicate that the model we applied fits the simulated and empirical data set well, again, it is very challenging to learn statisticians on non-programmers. And this becomes the motivation that we develop the tool in web tool to implement this method, which I will have a demo of showing the implementation of this method in the web tool. So beyond statistical modeling of spatial HIV data sets, measuring spatial accessibility to HIV-related resources is also essential. Again, it is the first step in detecting areas where HIV diagnosis, prevention, and treatment resources are not available or not met to the demand. So findings from measuring spatial accessibility will inform us regarding where we should target for resource allocations and interventions. So far, however, the simple measures, including density and proximity, which can be measured by a travel distance or travel time, have been predominantly used to measure spatial accessibility to HIV-related resources. These simple measures are subject to limitations. For example, density assumes that only the facilities within the predefined boundaries, so this could be the administrative boundary or buffering zones, are accessible. And proximity measures assume that only the nearest or the predefined number of nearest facilities are accessible. So in contrast, more complex measures such as the two-step flow chain catchment area approach and its Gaussian version are less commonly used in measuring spatial accessibility to HIV-related resources, even though there have been evidence that in other settings, not necessarily like HIV-related, that these more complex measures can better capture accessibility. So here, I would like to, left map shows the network route from the population weighted centroid of zip code to its nearest PrEP provider. So that belongs to the simple measure, proximity or travel distance or travel time based. And the right map shows the principles of the two-step flow catchment area approach, two SFCA approach. So as suggested, here I would like to mention a few words about the principle of this method. So as suggested by the name of this method, there are two steps in the calculation. First, for each supply location, so that could be one PrEP provider, we calculate the supply to demand ratio. That is, how much demand or how many populations this facility can serve. And the second, we draw a floating catchment area along surrounding each demand location. So that could be, for example, the population weighted centroid of an area. And then we sum up, we determine all those supplies that fall within each demand floating catchment area. And then we sum up the supply to demand ratios. And then this becomes the calculated spatial accessibility of the facility based on these two SFCA approach. The Gaussian version of this approach goes one step further. So it explicitly accounts for the distance decay effect. That is, the longer the distance between the demand and the supply, which could be, again, the centroid of an area and a PrEP provider, the lower the accessibility. However, in the traditional two SFCA approach, as long as the supply falls within the catchment area of the demand, so they are assumed to have the same accessibility. So in one of my recent publications, I systematically compared 25 different measures in quantifying spatial accessibility to PrEP providers using the New York City data set at the zip code population area level as an example. So we investigated first how the selection of different measures impacts PrEP shortage area detection. And second, we examine how the selection of measures impacts the findings on the association between PrEP accessibility and the social determinants of health, SDOH variables. So this map shows the locations of the 306 PrEP providers across the 164 zip codes as of 2020. And we can see that the distribution of PrEP providers are not even across space, with more locating in Manhattan and Bronx. And we also mapped the 5-year new HIV diagnosis as a proxy of PrEP demand. So which we can see that the new HIV diagnoses are relatively high in Brooklyn, Central Queens, Bronx, and Upper Manhattan. And also to investigate how the choice of PrEP accessibility measures impacts its association with SDOH variables, we included 6 different variables, which are those commonly used in PrEP and HIV research, including socioeconomic deprivation, income inequality, percentage of uninsured population, and percentage of Black, Hispanic, and Asian populations. So these are the descriptions of the 25 spatial accessibility measures that we compared. Again, I'm not going to introduce the details of each measure. Instead, I'm highlighting several things here among these 25 measures. First, there are 4 categories, including both the simple measures, density, proximity, as well as the more complex measures, the 2 SFCA approach and its Gaussian version. And second, we used both the new HIV diagnosis and the total population as the proxies of PrEP demand. Both have been used in the literature, so there's no consistency in terms of which one should be used. And the third, proximity is measured as the driving time to the nearest, 3 nearest, and 5 nearest PrEP providers. So in order to account for the sensitivity regarding how many we should predefined to calculate proximity. And when the 2 SFCA and the Gaussian version are used to quantify spatial accessibility to PrEP providers, we used different cut-off driving time to define floating catchment areas, ranging from the 10 minutes to 30 minutes. So these are the commonly used cut-off used in PrEP accessibility research. And also we want to see if the results are sensitive to the choice of the cutoff values. So here are the results from our comparison. Regarding the correlations between these different measures, so they can be as low as 0.32 and can be as high as 0.98. And the negative correlations between those proximity measures and other measures are expected because the longer the driving time, the lower the accessibility. And another notable finding in these correlation results is that compared with accessibility based on the traditional 2-SFCA approach, PrEP accessibility based on its Gaussian version have a higher correlation across spatial scales. So in other words, the measures are more consistent when different driving time cutoff values are used. And the spatial patterns of using different measures are shown here. For simplicity, we define zip codes in the lowest quintile as PrEP shortage areas, and the zip codes in the highest quintile as PrEP OSIS. And in the first two maps that uses density measures, we can see that the PrEP OSIS scattered across New York City, and some zip codes in Manhattan are identified as PrEP shortage areas. And a lot of zip codes are considered as not having like zero access to PrEP providers. And the patterns from the three proximity measures, so that's like the remaining three maps in the first row. So we can see that the PrEP OSIS, they are mostly located in Manhattan and Bronx, and some are scattered in Brooklyn and Queens. And interestingly, so some zip codes in North Bronx are identified as PrEP OSIS only when this proximity measure is used. And the rows 2 and 3 show the results of the patterns by using the traditional 2-SFCA approach. So and the second row is the results from using new HIV diagnosis as a proxy of demand. And row 3 are the results by using the total population as a proxy of demand. So we can see that at the same cutoff distance, by using different proxies, so the patterns are similar. However, it is observed that with longer cutoff distances, the patterns drastically changed. So for example, at the 30-minute driving time cutoff, many zip codes in Queens are detected as PrEP OSIS, while some zip codes in Lower Manhattan, they are not detected as PrEP OSIS, even though these areas are when the shorter like driving time cutoff value is used. So in contrast, the spatial patterns of PrEP accessibility based on the Gaussian version of 2-SFCA are more consistent across different spatial scales because again, so the demands and supplies are discounted in the calculation by using the distance decay function. So, and we also observed the impact of using different proxies of PrEP demand in these two rows of maps. When the total population rather than the 5-year new HIV diagnosis is used, additional zip codes in Southwest Bronx are identified as PrEP OSIS, while this is not observed when the new HIV diagnosis is used as a proxy. And this figure shows the regression coefficient between PrEP accessibility and those social determinants of health variables using different measures. So those inconsistent findings from the majority findings are highlighted in green boxes. So again, I'm not going to detail the findings from this scale because there's too much information, but we can see that findings are much more consistent when the Gaussian version measure is used. So the top 5 rows of the results. So the main takeaway from this study is that the Gaussian version of 2-SFCA approach is recommended for quantifying spatial accessibility of PrEP providers because it provides more consistent findings in the PrEP shortage area detection and the association between social determinants of health and PrEP accessibility across different spatial scales. And density measures are not recommended for small areas, such as zip codes. And proximity measures, surprisingly, they're more stable, provide more stable results than density across scales. And how many nearest PrEP providers should be chosen in the measure probably not be that critical because it is also a measure that accounts for the distance decay effect. And our findings also suggest that probably there's a need to reflect on the use of PrEP demand in calculating PrEP accessibility. And the difference on the findings, especially the patterns, could be because the number of individuals at high risk of acquiring HIV within a zip code is not perfectly proportional to the total population within a zip code. And future research should compare different measures at other spatial scales in different contexts beyond New York City, and to account for the transport mode into the analysis or into the measurement beyond driving time. Again, so these complex proximity, these complex accessibility measures that we can use to characterize or measure accessibility to HIV-related resources are not that commonly used, or I would say rarely used, probably because of the expertise that is needed to implement it. That's also the reason why we propose to implement these measures in our web tool. So now, after we detect the HIV resource shortage areas, the next question is, where should the resources be located? In fact, this is not simply locating the resource at the shortage areas, because adding resources will affect not only the area per se, but also the areas nearby, because there is this spatial interaction involved. So a more objective approach is through spatial optimization, a method that to maximize or minimize an objective function. And this function could be maximizing the coverage of healthcare facilities or minimize the total travel cost that we need to overcome to access the healthcare facilities. And one commonly used model is the spatial optimization. In spatial optimization is the location allocation model with the aim to identify the optimal assignment of clients and facility locations. So although these spatial optimization technique has been well researched in the literature or in spatial data science, and could provide important insights regarding where we should intervene or where we should regarding resource location and allocation. But to the best of my knowledge, it has been rarely applied in HIV resource location or allocation. So in fact, I talked to a couple of health professionals in Dallas and got to know that usually the public and private healthcare facilities providers, they volunteer to provide PrEP. And no objective approach such as spatial optimization has been applied to help PrEP planning. So in this talk, instead of introducing the technical details of spatial optimization, which involves the mathematical programming, so I'm only going to use an example that shows what insights this objective function or technique can provide to expand PrEP providers using Atlanta as an example. So this map shows the PrEP spatial distribution of PrEP providers represented by the red hearts on the map. And we also show the new HIV diagnosis between 2017 to 2021. And we see that in Atlanta, the PrEP providers do not necessarily locate in areas with a high number of new HIV diagnoses. And the existing spatial distribution of PrEP providers in Atlanta only serve 94 out of the 127 zip codes within 5 miles. And so those zip codes that are unserved within 5 miles are represented by the red dots. So the red dots represent the population weighted centroids of the zip codes. So this leaves 33 zip codes with 1,529 new HIV diagnoses unserved. So the next question is, what can we do to improve PrEP accessibility in Atlanta? So here, if we are using the spatial optimization approach, the objective would be to maximize the PrEP coverage in Atlanta. So we consider 2 different scenarios. First one is by adapting existing HIV testing sites as PrEP providers. So which is the HIV testing site is represented by the yellow heart layer. So by the results show that by adapting 20 HIV testing sites, as shown in the star layer, 31 additional zip codes are served within 5 miles. So that leaves only 2 zip codes unserved with 127 new HIV diagnoses. That's approximately 8% of the demand. The scenario 2 is that what if we do not adapt existing healthcare facilities? What about we construct new PrEP providers over the continuous space? So, for example, by distributing or developing mobile clinics. So based on the spatial optimization approach, we show that by recommending 16 locations over the continuous space as optimal sites, so these will serve all the 33 zip codes within 5 miles. And these recommended locations are represented by the square, the yellow square layer. And you can see that these 2 different scenarios provide straightforward insights regarding where interventions should be developed. But of course, these are very preliminary analysis, and there are several limitations we can address in future analysis, including, for example, using transportation-based travel time rather than simple travel distance, and by not assuming that all the new HIV diagnoses live at the population-weighted centroids of each zip code. And also, beyond HIV testing sites, we can consider substance use treatment facilities as alternative PrEP providers from a syndemic perspective, because in the past years, there have been new threats to the progress of reducing the number of new HIV infections. And one of them is the opioid crisis. And it has been reported that 1 in 10 new HIV infections occur among people who inject drugs. But unfortunately, 95% of the outpatient substance use treatment facilities have not yet implemented HIV PrEP. And this is a big miss for vulnerable and hard to reach patients. And interventions to co-locate PrEP services in the substance use treatment settings may minimize the logical barriers and improve the uptake of PrEP. So the next question is, which substance use treatment facilities should be targeted, where the spatial optimization can play an important role? So similarly, no web tools have supported this analysis. So to address the challenges I discussed in the previous slide, we propose to develop a tool to support Bayesian spatial signal modeling, advanced GIS methods to measure spatial accessibility, and spatial optimization techniques. In fact, we submitted an R1 proposal to NIMH last year with the title Leveraging Extensive Social Determinants Data and Spatial Data Science to Reduce HIV Incidence Across the US and the HIV Epidemic Counties. We received an impact score 29 and have received the official JIT request from NIH. So fingers crossed that our proposal will be funded soon, so we will have more resources to support this work. So this is a screenshot of our web tool. It has 3 functions. Again, signal modeling, accessibility assessment, and location allocation modeling. And this web tool is implemented with the cloud computing infrastructure, and it can be deployed as a container, which is lightweight and portable to any health department. So we have a demo here. So under this statistical modeling tab, if you select the geospatial file, it's loading. Specify the distribution type, either discrete or continuous, or and the model new engine, either the posterior approximation approach INA or MCMC approach NIMBLE, and select the outcome and covariate, and then you can run the statistical model. So it will show the modeling results, including the mass, regression coefficients, and model diagnosis results. So this work tool also implements the truncated Poisson distribution to model sensor data sets via NIMBLE. So as you can see that from the left map, many counties have suppressed values in the category -1 to 0. So if we're using this model, again, you don't have to throw these like units, these values from the analysis. And you can see that using the model we have seen in the previous slide, all those, we have the estimation for all those counties without like any suppressed. And because modeling these sensitive values takes much more time than modeling a complete data set, around 5 minutes. That's why I didn't record a demo here. But for information, it is implemented in our work tool. For this spatial statistical modeling function, so the next steps would include first the price sensitivity analysis, and add one button that if we change the level of risk, so we can visualize the changes in HIV risk. And we'll also implement the function to detect emerging hotspots. And this is one important advantage that I would like to highlight, because again, in Bayesian approach, the future unknown rates can be treated as unknown parameters in the inferential framework. But we can provide a posterior estimation distribution for it and quantify the uncertainties. And of course, we will need to implement more models in addressing issues such as zero inflation, because for rare phenomena such as late HIV diagnosis at the statistical level, a small area level, there is a chance that there are a lot of zeros, so than expected. So these issues should be explicitly addressed to avoid estimate bias. And under the accessibility assessment tool tab, our tool also implements the two-step floating catchment area approach. So there is also a demo here. So by providing the demand and the supply points, which you select there at this stage, they're expected to be point layers. You select the demand and supply points, select the variables that indicate the demand size, for example, the total population, and the supply capacity, and specify the distance, threshold distance, and then a accessibility index map will be provided. The next step for this function is to implement transport-based accessibility by different modes: walking, public transit, cycling, and driving. But that means additional data set will be needed for the computation. For example, we will need GTFS data set, including the schedule of public transit, bus stops, the routes, to calculate public transit-based accessibility. And we also need to compare different tools for multimodal transport routing. For example, from the left map, that map on this slide, the commercial tool from Google and the open source tool R5R have different routes, for driving. And finally, we can also characterize space-time accessibility of HIV resource, such as PrEP, based on different transportation modes, accounting for the provider's opening hours, as you can see in the slide. The findings will guide when and where during a day we should intervene. And for the location allocation tool function is still on development because it is more challenging than implementing the accessibility assessment tool because this location allocation is an iterative process and is much more computationally demanding. But the goal of this tool is that by uploading the candidate facility size, the demand size, which could be the individuals or centroids of areas, and or the current facilities data, the user will be provided with a recommendation for resource allocation and allocation, maximizing the coverage of HIV resources or facilities. So of course, like beyond what we implemented or will implement in our web tool, there are other research opportunities in spatial data science to support HIV research. For example, using human mobility data to characterize activity space of people who is living with HIV, or using geotagged social media data sets to build social media-based HIV risk behavior index and to incorporate the telehealth into the traditional accessibility measures to quantify, for example, PrEP accessibility. So if you're interested, you can refer to the literature for more information. So finally, I would like to acknowledge the support for this work, the support I received from AIDSView, the View Fellowship, and the Data Science Initiative seed grant from my previous institute, University of Oregon. And of course, I would like to thank my longtime collaborator, Dr. Yusuf Ransom, and my former PhD student for programming the tool, Dr. Insang Song. And I would also like to thank CIRA for their peer review feedback of the R01 application in 2023. And finally, on behalf of Yusuf and I would like to publicly acknowledge the faculty, staff at Yale, community leaders, and those at the Connecticut Public Health Department who provided the expert feedback on the first draft of our R01 proposal, which definitely strengthened our proposal. And finally, thank you for your attention and attending this talk, and I'm ready to take your questions.
Great, thanks so much, Henry, and congratulations on an incredible body of work. I think your methods work has really helped to add kind of a different level of, finer level of precision in terms of thinking about kind of where the challenges are with HIV, PrEP, access, and equity. So, and congratulations, we're pulling for you on this R01. Congratulations on
Thank you.
Score.
Yeah, we're excited. Yeah, fingers crossed for positive results. Yeah.
And it sounds like our audience is already has some questions for you. So there's a question in the chat by Lucy. Lucy, do you want to unmute yourself, or would you prefer me to read the question?
Oh, I see the question there.
Okay.
Yeah.
All right.
Thank you.
I think they're unmuting. Someone's unmuting.
Yes. Good morning, everyone. It's evening here in Johannesburg, and this is a very interesting talk. Something that is totally up my alley. As a spatial epidemiologist, and it's always wonderful to see new techniques evolving. So maybe I just have two questions. So the first one was whether the web tool is based for use by others, and whether it can be used outside of the US. And the second question was about the time to the PrEP provider, the PrEP facilities. Just wondering whether the approach that was used to model was assuming that the clients were traveling on a straight line, or was it a convoluted kind of a journey? So that's the kind of question that I had this evening. Thank you very much.
Yeah, thank you, Lucy. Great question. But so for your first question, so yes, the answer is yes. This tool will be available to be used by others. Yeah, so everyone can use it. So we will have, so this one will be deployed to our server. So anyone who is interested in using it will have access to it. And for the coordinates, yes, this tool will also support the analysis of the coordinates outside the US. In fact, beyond the geographical extent, so this tool can be used to be honest, any geographic phenomenon that have similar characteristics of HIV data sets. So even though we developed for the purpose of HIV data sets, it can also be used for other spatial data sets. And for your second question, the answer is no, we didn't assume a straight line. So we use the road network distance, actually the travel time, the driving time. But still, this network distance travel time is also limited, as I mentioned in the slide, because we did not account for the real physical barriers or the availability of transportation modes. So we should like to quantify these accessibility based on different transportation modes to account for more realistic barriers in practice. So that's our next step of this tool.
Lucy,
yes. Thank you.
Well, thanks for that question. I hear your enthusiasm for the tool, which it sounds like is really getting some excitement. So on that point, these sorts of tools, your tool uses Bayesian analysis, which requires specification of priors, right? Prior specification. how is that implemented or specified in this web tool?
Yeah, thank you. Yeah, that's a great question because it's important to like consideration in implementing Bayesian methods because we combine both the prior information and observed data for statistical inferences. So for now, we have those pre-specified priors that we assume that are appropriate for spatial epistemology of these data sets, and they are not informative. They are vague priors, so non-informative. So that means the data will dominate the observed data will dominate the statistical inferences. But let's say if we have the more informative priors, let's say we have a lot of like similar projects, we have like more informative prior that we can specify to those unknown parameters. We can definitely incorporate that in the tool and specify informative priors. But one advantage of Bayesian approaches in the spatial statistical modeling I would like to highlight is that, again, it provides a full posterior distribution for those unknown parameters, even though we are using non-informative or vague priors in the analysis. So in that case, again, we can quantify the uncertainties associated with these estimates compared with by providing only the point estimate that we obtain from those traditional frequentist-based approaches.
It sounds like that might have been also part of the next steps that you had mentioned with doing some sensitivity analysis on your priors.
Yeah.
Prior sensitivity analysis.
Mm-hmm. Thank you for this question, Laurie.
All right. Yusuf, I see your hand up.
Yeah, so thank you again, Henry, for a great talk, and certainly excited to be working with you. I know one of the things that we touched on briefly is the opportunity for not only for the tool to map the data, but to actually understand the underlying distribution of the data based on social determinants. So in the model, for instance, you have things there that include income inequality, certainly prevalence of in different races and ethnicities. Can you talk a little bit about how understanding the contributions of those data would allow practitioners to kind of understand what are the underlying sort of, I would say, things that potentially contribute to the patterns that we're seeing?
Yeah, thank you for this question, Yusuf. Yeah, I think we had this discussion before. So that's, again, so okay, no, this one. That's why I'm thinking that we should be able to have a button or tool that we can change the levels of risk factors, and then we see the changes in HIV risk. So from a practical perspective, health practice perspective, so this will allow those researchers and practitioners to see what if we're making these modifications to these modifiable, I think in most cases, the modifiable environmental factors such as PrEP or HIV testing, substance use, treatment facilities. So what would be the changes in HIV risk? So that will be a very straightforward and a visual way to see what impacts will be by modifying these factors. So yeah, for sure, we are going to, that will be the next step.
Thank you.
All right, we are right at 3 p.m. Thank you so much, Henry. Maybe you can pop in the chat in case other people have some burning questions for you. Maybe you could go ahead and pop that in the chat. And also there was a note from Daniel that when you close out, there's going to be a very brief survey. So folks, please, as you go, please make sure to complete that if you can. But thank you again for an illuminating talk. You're an incredible scientist. You know, I'm a big fan of yours. And thanks for sharing.
Thank you, Laura. Thank you so much for taking this discussion. Yeah. Okay. Thank you, everyone. Bye. Have a good one.
Thanks, Dr. Luan.